So for children, danger is not just the presence of violence, it's the absence of love. And sometimes many of us, a large proportion of us, really struggle with expressing love, connection, emotion, belonging within a family because of the way we were parented.
In pediatrics, part of the work is to meet families at their most vulnerable during illness, transition, fear, and change. And while we're trained to diagnose, treat, and manage disease, some of the most powerful medicine we offer never comes in a prescription bottle. It shows up in the relationships we nurture and protect. In this episode, we're exploring how trauma, attachment, and the family system are core to our understanding of our patients. The way we as providers listen, screen, educate, and support can change the trajectory of a child's life. This is Charting Pediatrics. Joining us for this episode are two incredible authors and powerful voices in this space. Benjamin Perks works for the United Nations in New York on human rights and child development and protection. He is a senior fellow at the Jubilee Center at the University of Birmingham in the UK and an associate member of the Department of Social Policy and Innovation at the University of Oxford. He is also the author of the recently published book titled Trauma Proof. Susan Queso is a licensed therapist, speaker, and author. She serves as a board member and advisor for the LIVE Project, and she is the author of the book, The Parent-Teen Connection, How to Build Lifelong Family Relationships. Benjamin and Susan, welcome to the podcast.
Thank you so much.
Thank you. It's great to be here. Thank you for having us.
You guys have such varied backgrounds. I'd be very interested, as will our listeners, in kind of what you do every day. Benjamin, tell us about all of the work that you do.
Well, I work on global advocacy with governments around the world on child development and child protection for the UN. So, for example, I just came back from a major forum with the Queen of Spain, the General Director of WHO, and about 30 ministers, looking at how do you take a public health approach at scale globally to prevention of child maltreatment.
And Benjamin, what's your background that got you into this space of child development?
Well, I was very idealistic as a young person, and I chose to have a career in the UN, and it's evolved. In the beginning, I was working in humanitarian contexts like Afghanistan, in India after the tsunami, in conflict situations, and eventually I became kind of a human rights diplomat for the UN. So I've been working with governments on really promoting child survival, development, and protection across the board.
You bring such a global perspective on this topic to our conversation today. Thank you. And Susan, how about you? What's your day-to-day?
Oh, my day-to-day is sitting with teenagers and families, and I absolutely love my job.
In clinical practice. Yeah.
In clinical practice, working with families to have stronger connections, to have stronger bonds. And, when families are connected, cooperation happens and people are happier.
Yeah, I love that. Benjamin, let's start. So help us define what we mean by trauma for the purposes of this conversation today.
To me, trauma is a neurobiological reaction to something that's really hard to process. So, for example, if a child grows up with a sense of not being loved or experiences violence, then it's a potentially traumatic incident. And it's what happens after that incident that determines whether it will evolve into toxic stress and trauma and an elevation of the stress response system, which can have a lasting impact on the child.
Right. So the experience of trauma is part of the human condition, perhaps in many ways, but it's what happens after that may define the trajectory, if I'm understanding.
Can I give an analogy?
Please.
If I'm going skiing next week here in Colorado, if I have a knee accident and I do nothing about it, it's likely to get much worse. If I go and get it treated immediately or addressed, it will improve and recover. The problem with trauma is it's so taboo that often people suffer it in silence and they're never able to address it. And that's why it morphs into life-lasting costs.
Well, Benjamin, we wish you none of that on the slopes. Nothing but bluebird sky and good snow, I hope, for you in Colorado. Susan, can you help us kind of paint a picture of the current landscape of trauma, and how informed are we as providers, and I guess as parents as well, about the status of trauma in our patients and our kids?
Well, I think Ben just said it a few minutes ago. There's so much stigma around talking about things that have happened to us that have been painful in our lives, and not talking about it, burying it, thinking it'll go away, actually doesn't make it go away. And so really people being able to talk about it and heal from it. And then when we look at parenting specifically, if a parent has had trauma in their life and it's not something that they've processed and worked through, that can actually seep out into their relationship with their children, whether that is the way that they parent their kids, maybe their inability to be attuned and be affectionate and just be a stable parent for that child, regulate themselves emotionally. All of these things really come into play.
So this is a really interesting concept that I'd like to explore a little more, because, some of those things we've thought of as parenting skills, right? And how do we teach parenting skills in clinical settings? But I think what you're saying is that this may be manifestations of things that happened to a parent long ago,
yes,
right?
Yes.
So what might you see, Ben, in a family dynamic or a family relationship that I might miss as a pediatrician, but might be a manifestation of trauma in that family dynamic? What are the things we should be looking for?
Susan has this brilliant idea in her book about felt connectedness. Right. So for children, danger is not just the presence of violence, it's the absence of love. And sometimes many of us, a large proportion of us, really struggle with expressing love, connection, emotion, belonging within a family because of the way we were parented. Parenting is automatic and instinctive. So unwittingly, we can often pass that sense of the absence of security to our children simply by not making them feel loved. Families that don't communicate, families that are not responsive or attuned to the needs of a child, families where there is the presence of verbal violence or even physical violence. All of these things really harm the neurobiological development of the child.
Susan, I'm guessing that if a family is coming to see you, they are probably biased to wanting to explore some of these topics in the clinical setting, but certainly we see families as pediatricians where that may not be the case. So what are the things that we should be looking for that might indicate some type of lack of attachment or disconnection in the clinic? What are the things we should be asking about our patients to explore this super important topic?
I think it's really important. I know pediatricians, first of all, do an amazing job of supporting families. And it's really important, I think, when a child comes in, and I'm talking about an older child, we're talking to that child and asking questions about how the child is actually doing, but really framing some questions that really look to how the family system is doing. For example, you could ask a child and ask the parent, has something significantly changed in your family? Is there something different that's happened at home? And asking both the parent and the child, how does that impact you? And what the pediatrician is doing is not only finding information about what's happening with the family, but also finding out information about how they are talking to each other, relating to each other. Are they able to talk about this in front of someone else? The pediatrician is also modeling what healthy communication is and being open.
So changes in the family would be a way to get at it, Benjamin?
I think it's a really important point, and Susan's touched on that. It's important to remember for a pediatrician, I really admire the work of pediatricians. I work very closely with Nadine Burke-Harris in California and others.
Excellent.
And I think that it's really important to remember that if you're communicating with a child, you might be the only adult that's having a proper conversation where you're listening to them. Many children are growing up in situations where they're not heard, where they're not able to have a conversation, where the level of disconnect or violence at home prevents them from having that. It may sometimes not seem to be an emergency or a family in trouble, but just the absence of communication. So making sure a child is heard and feels that they can communicate with you and can make a connection with you makes all the difference for children at risk.
Let's talk about some of the manifestations of trauma that is not, say, properly addressed or managed in a child. What might you see, or what might bring a patient into a clinic? What types of behaviors or things might we be looking for?
Yeah. Oftentimes the child is the identified patient, and we really need to look at what else is happening in the system. And so a child, behavior is communication. And so a child might be misbehaving. They could be anxious. They could be down. They could be struggling in their relationship with their parent. Could be oppositional, defiant, that kind of thing. And really understanding that, because oftentimes when I say a child is the identified patient, it's almost sometimes that children are vilified for their behavior, and we need to be moving towards understanding before we are vilifying children. And which is really sad in my mind, that we just want to teach parents that behavior is communication, and to really pause and really try to understand what the child is trying to communicate.
Yeah, I think there's this great line about what happened to you, right? Rather than asking what did the child do, what happened to you? Because when behavior is inconvenient, it's often communicating a challenge the child can't address, and the child may need to be listened to in that situation. I think the other thing that's really important is that in adolescence, risk is much, much, much higher for almost every major well-being threat, from addiction to being involved with crime or violence or alcohol or obesity, is much greater when the higher the level of trauma, or the less the child feels safe and loved at home. So often you're having a conversation with a teenager about health risk, but that's just a symptom of something deep inside that is missing and needs to be addressed.
So for clinicians who may not think of this concept of attachment as being central to their medical practice, what are the signs that an insecure attachment relationship within a family might be manifesting itself in a negative way for a child? What are the things you look for? Is it similar to the trauma, or is there other things that we should be looking for, Susan?
I think, I know pediatricians have a super small window of meeting with their...
Of time. Yeah,
with time. So it really, really is hard. And sometimes it is almost just a felt sense of what the pediatrician feels, right? The energy in the room between the child and the parent when a child is younger. It's really looking at, can the parent respond to the child? Are they attuned? Is the baby crying and the parent is able to respond? Or are they getting really flustered? Or are they just ignoring the child? That really shows attunement, which would be a secure attachment when they can respond. What we call a serve return is what that is. Mm-hmm. The baby serves up a need, the parent responds by comforting the baby, and then that security and safety is built. That's what a secure attachment. And then over time in the adolescence, again, what we're talking about is a parent can be attuned, listen, and respond to a child and validate how they're feeling, and looking for signs of that when they're in the office.
Right. That's interesting. In the context of an adolescent visit, what we're trained on as pediatricians is spend some time with the child and the parent and then have a conversation without the parents, right? But to explore that attachment issue, you kind of need them all in the room in some ways to see that serve in return.
Yeah.
Benjamin, I'm curious because you think about this at a macro level, at a a national level, if not a global level, in terms of picking up these children at risk. So Susan gave us some tips about how to do that in the clinic. But as you're thinking about this and having conversations with government ministers, et cetera, how are we addressing this at scale in terms of recognizing kids at risk?
Well, it's not just about recognizing kids at risk. What you have to have is a prevention system for the whole population. So we've tended to think about children being at risk as kind of being 1 or 2% of the child population, but that's completely wrong, because now we have these population level surveys, and the CDC and others do them on adverse childhood experiences. And what we see, which are potentially traumatic incidents in childhood, and what we see is that more than half of Americans have had one adverse childhood experience, and around 15% have had 4 or more. So you can't identify everybody that's vulnerable. What you need to do is prevent at scale. So in America, there is so much science around, and RCTs around, really strong evidence-based parenting programs that improve nurturing care, improve attachment, reduce maltreatment, improve parental mental health, but they only reach about 5% of the American population. So I would say that those need to be dramatically scaled up. They need to be treated like a vaccine, something that should be a public health strategy for everybody in the country, and they should be universal, progressive, so they're made available to everybody, but there's more for those that need it. The return on investment on that is huge, because adverse childhood experiences in health costs alone for the United States and for North America and Europe is 1.3 trillion per annum. Cost a fraction of that for a parenting program that's universal. I think also things like parental leave. It's a great strain on attachment in the United States that we have such poor provision for parental leave. So I think these are 2 of the policy interventions that carry a huge return on investment. And really, in many ways, you could argue at the population level that parent-child attachment, the quality of the relationship, is the greatest economic asset we have. It determines all learning. It's the foundation of learning, of progress, of growth, which drives economic growth and democratic development. So we should be taking it much more seriously as a national and a global public good.
Well, amen to that.
Yeah.
I agree. Susan, I want to return to something you said earlier, which is around the fact that, I guess, inadequately addressed trauma in a individual can manifest in their parenting relationships with their child. So if you see this in your clinical practice, and let's say that it's the child who is the patient,
right.
But how do you approach that if you're worried about the parent and the parent needs help? How do you address that in your practice?
So I do an intake with parents only first for a reason. So I can hear about what their childhood was like. So I'm not only asking questions about what's going on for that child, I'm asking about family history. I'm asking about their own childhood. I'm asking about, mental health issues that run in the family, that kind of thing. And usually I'm also building rapport with the patient's parents at the same time. And, about halfway through, it's that time where I can actually lean in a little bit, and they will share with me about what their experience has been more in depth and how they feel. And that is the time where I can offer additional services. I can give them referrals. Most importantly, I can give them some empathy and understanding, which is very healing for them. And when I move forward with that child in therapy, I know what has happened to that parent and can make adjustments in whatever I'm doing with that child. And also, I also always include parents in the process when I'm working with a child. And I'm not sure many therapists do that. Right now, we're really seeing kids more in individual therapy and isolation. And we really need to be including parents, because parents are parents for life. I don't want to be their therapist for the rest of their life, right?
Yeah. It's an interesting concept because, we talk about generational poverty, for instance, but there is this kind of potentially generational lack of attachment that if it's not addressed, at some point it's going to impact the successive groups of kids that follow, right?
It's completely intergenerational. We know that now from a lot of the research from psychology, but we also are learning it from genetics and other things. There's a lot of research around the situation, for example, of Holocaust survivors and what happens to their children, their grandchildren, the way that trauma is passed down through the generations. Trauma, and we talk about trauma and the lack of attachment or insecure attachment. These are two broadly very similar impacts on children and are mutually reinforcing. I want to just come back, and I'd love to know what Susan thinks about this as well. There's now a lot of evidence, and there was a systematic review by World Health Organization of parenting programs, but it demonstrated that when parents learn the skills to make and it's just about skills, right? Learn the skills to forge a better attachment with their child, the outcomes of the child are, improve. We have our overwhelming evidence of that now. But what we didn't expect was the mental health of the parent improves as well. And that's because love, which is what they're learning to do, to express love and connection with their children, heals. The better attachment, the better care a parent can provide for the child, the parent will also heal in that process, right?
Yeah. And I mean, you think about it, right? Kindness breeds kindness. It feels good to be kind, right? Same thing with parenting, right? When they know they are working hard to be a better parent and they're giving their child what they didn't have, it can be an overwhelming feeling for a parent of joy and happiness and healing to give a child what they didn't have growing up.
Well, I love this pivot to thinking about how we address this problem and some of the solutions. Love, emotional safety in the home, that relationship between parent and child. Susan, help us understand this a little bit. The focus of your book is on teenagers. Teenagers are, for all of us as parents, it's probably the most daunting aspect of being a parent. So the biggest challenge. So how do you address that in your clinic in terms of creating love, emotional safety where maybe it's strained or challenged in a home?
Yeah. I love teenagers, by the way.
Who
I
doesn't?
still have one in my home. My oldest child is 27, but I still have a 12-year-old. And, it is very different to be a teenager too. And so hopefully parents have a little empathy for what they're going through. But, I think there's just this feeling that parents think that their teenager doesn't want to hang out with them or doesn't want to tell them things or would rather be with their friends. Kids are individuating, they're differentiating, they need to spend time with their friends. That's what they're supposed to do. But they do want to spend time with their parents. They do want to have a relationship that is emotionally close. I hear it every day in my office. And so parents may not know how to cultivate that. And that's one of the reasons why I wrote the book, is to help parents create that feeling of connectedness, to create safety where their child will come to them when they're struggling. Oftentimes, I work with children that have thoughts of self-harm and suicide, really serious things that are happening to them. And they tell me, I want to tell my parents, but we don't talk about stuff like that at home. We don't talk about how we feel. I don't want to burden them. They're busy. Those kinds of things. They really, really want to reach out for their parent, but there has to be safety there to do that.
So when you hear that and you bring the parents into the conversation, what are some tips that you give to the parents to start on that journey of creating more dialogue, more communication?
So I think that, parents are just trying to be really good parents. But oftentimes they get stuck in what I call the parent role, which is the instructional part of parenting. And there are all those interactions that begin with have you, when are you going to, you need to. And that is actually not building the relationship with your child. In fact, if my husband came home and, after a long day of work and the first thing he said was, you haven't done that project yet. When are you going to finish the laundry? It'd be hard to have a relationship with that person, right? So I talk to parents about spending more time in what I term that mom, dad, caregiver role, that warm, loving side where you're experiencing joy with your child. You're cultivating the relationship. And so you're creating belonging at home. And whether that be having dinner together, playing games, teenagers still like to be silly. I mean, these are the things that they need to be doing to cultivate that relationship with that child.
Benjamin, you talked about how vulnerable teenagers can be. So how do you think about this?
Yeah, I think that firstly, it takes a bit of the steam out of it if we recognize that adolescence is just a normal essential neurobiological process that takes somebody from being a child to an adult. All of these changes in the brain, they're actually biological. So teenagers can't be blamed for things that may seem like inconvenient behavior.
Yes.
An important point about adolescence is like striking out and finding your own identity. They realize that in many ways that parents are a bit flawed, that parents are not perfect. That's one of the things that's a challenge. But then they look for these things like emotional spark and creative exploration and novelty and excitement. But the cognitive control system that can manage risk in all of those things is not fully online until the early 20s. So, with all of that creative exploration going on, you can imagine that the Beatles bunked off high school and went and practiced, right? And that created something that was of such value for the world, and it's fabulous. But the same desire for creative exploration and novelty and social engagement could also lead somebody to joining a gang or doing something high risk or getting involved in drugs. So the one variable that makes all the difference is the emotional proximity to the parent, the connection, or everything that Susan writes about, the connection between the child and the parent. I know many people say that you can tell, Alisa Demore, for example, says you can tell the safety of a child by their emotional proximity to their parent.
It's an interesting concept. Susan, let me ask you a question. We know that vulnerability is important in human relationships. Where does that come into this? I mean, we don't want to lay the burdens of being an adult on our kids, but if we're not sharing any of our inward emotional experience, I could see it being a challenge in terms of some of that bonding. So how does that play a role in the parent-adolescent relationship?
Yeah, it's a great question. And parents do have to talk about how they're feeling. They need to talk about struggles, disappointments, failures, and how they handle those and what that actually feels like with feeling words. Because what that does is normalize the conversation. And then teenagers, young children as well, will start using that same language. We'll feel like, this is natural. This is how we talk at home. I can talk to my parents about how I'm feeling. I think that word vulnerability, when it comes to the parent-child relationship, vulnerability implies risk. And we actually don't want our children to feel like it's risky to share. So I work with families and how they can create more transparency, emotional transparency. What are the conditions in the house that are causing that child to feel at risk to share? And how can a parent work through those so the child can share openly?
You have this notion of transparency in your book, right?
Yeah. Emotional transparency.
Yeah. I think that's very interesting that particularly when children are beginning to realize that we're all a bit flawed anyway, when they become adolescents, leaning into that and having a conversation or being open about when things go wrong in your own, the workplace or elsewhere. So they also are able to get a good emotional map of the world, that things aren't always perfect, that you need to have moments of anxiety, normal levels of anxiety, proportionate to the situation to grow and develop. So life is not smooth and we need to help our adolescent children adapt to that by showing the way that role modeling the way that we address challenges, the way that we react when we feel vulnerable, and the way that we work through problems.
I really appreciate both of you and your investment and commitment to kids, first of all. So thank you, and the work that you do. This has been a great conversation. I love this concept of emotional safety and love being the protection against maladaptive responses to trauma, right? Because we're all likely to experience some adverse life events along the way. That's the human condition. So I love this concept. As we wrap things up, I'd love to know, because you represent such different perspectives on this, what makes you hopeful about the future for kids?
I think, I've said that I think the greatest economic and social asset a society like America has, or the United Kingdom, where I come from, is attachment at the population level. The greatest public health threat is the absence of attachment, is the presence of trauma in childhood, because it has huge costs. But what makes me really hopeful is that we're the first generation in history with the scientific knowledge to be able to address that, to end that endemic. It's been an endemic throughout the whole of human history, but it's been primarily kept quiet because of chronic shame and taboo and stigma. We are now getting past that, and we're also evolving the science to end that endemic. And that gives huge hope for the future. It's a very difficult time in the world in many ways, but this is one good sign that we have.
Mm-hmm. Susan?
I think that, a lot of people need research, right, to make changes in their lives. And right now we do have a lot of research, just as Ben was talking about what a secure attachment can do for a child, about what authoritative parenting, that style of parenting, can do for a child. And so I think we just need pediatricians can give that information to their parents, when they come in. So I think that we have lots of good information. I think we're making progress in people talking more about their mental health, really understanding the support that teenagers and young people need. And I just think that we're making progress. Yeah.
You just mentioned authoritative parenting. We should probably explain that, because we hadn't mentioned that before in the conversation. So I guess the best, for me, the way of describing that is it's when parents are demanding, proportionate to the ability, but they're also supportive in helping those children reach the standards they can in life and helping them to flourish. Often parents can be too demanding and not supportive, or overly supportive and not demanding.
Correct.
Getting the balance between those things is what we now call authoritative behavior.
Yeah.
So not necessarily a negative, but something that needs to also be accompanied by other skill sets as a parent. Is that fair?
What do you mean by
authoritative parenting? Or is that, authoritative parenting doesn't sound like it's infused with love, but maybe I'm misunderstanding.
It's actually very high in warmth.
Oh, it
authoritative is high in warmth. Authoritarian
is
the one that maybe you're thinking,
yes.
That's the high demand.
Okay, got you.
High demand,
there's
no support.
No warmth and not very much warmth.
So authoritative is high expectations, but associated with love and support. Is that fair?
Parental warmth. And there's also communication, right? That conversation back and forth where, okay, tell me why you want to go to the party, right? Instead of the answer just being no and cutting the child off, kind of that open dialogue.
Great.
Yeah, because children need parents to be demanding and set standards and boundaries, but they also need to do that in the context of love and support to help them to flourish. We want our children to flourish.
It seems like that difference between the word authoritative and authoritarian is particularly relevant in 2025 and 2026. We need to understand this.
Definitely. It comes from a quadrant. So somebody put together all of the history of parenting research, and they came up with this very simple quadrant, right, of demand and support. And authoritative was about getting the balance right between those two things in parenting.
Yeah, which takes a lot of work when you're in the middle of parenting a teenager, especially, of where is that balance? Yeah.
Thank you guys so much for joining us today.
Thank you so much.
Real pleasure to be on.